Welcome to Doctor's Desk. This is my second video in case discussion series. So I'll be presenting you a case called Hodgkin's lymphoma, which was one of my earliest cases I encountered during my internal medicine, and I'll walk you through the case step by step, focusing not only what I found, but also why each clinical feature mattered in guiding us towards the diagnosis. So let's get into it. This is demographics. This 31-year-old male, a tiles worker from southern part of India. His occupational history is tiles worker, which mattered because he was exposed to chronic dust, silica, and other chemical exposure, which can modulate his immune function and cause the disease. He presented with symptoms like easy fatigability and weight loss, which is very significant, 10 kgs in 1 month, and he had complaints of appetite loss. So why these are significant? Because unexplained weight loss, constitutional decline, and anorexia raise concern for systemic inflammatory or malignant processes. And specifically, we can say it comes under the B symptoms category in lymphomas. History of presenting illness: he was well until 20 days earlier, after which he developed progressive fatigability, weight loss, which is significant, and loss of appetite. He was initially evaluated elsewhere and found to have anemia and jaundice, and there was absence of other symptoms like abdominal pain, vomiting, chest pain, loose stools, palpitations, syncope, oliguria, and other symptoms. So these matters because in Hodgkin lymphoma often follows a subacute trajectory with constitutional symptoms long before lymph node diagnosis. In early phases, it may present only with anemia and jaundice. In past history, he is type 2 diabetes mellitus and is not on regular medications, and he has history of fever associated with night sweats, which is very classical in Hodgkin lymphoma, and he had no other comorbidities and no surgeries were done in the past. His personal history: sleep was reduced due to night sweats and loss of appetite, so he didn't eat much. So normal bowel and bladder habits. There was history of alcohol consumption for past 3 years. Why this matters? Because alcohol exposure in some cases of Hodgkin lymphoma, they uniquely report with alcohol induced nodal pain, although this patient was not, but it has been reported in some parts of the world. History of tobacco chewing for 1 year. His family history: there was no significant family history. Coming to the general examination part, on examination he had icterus and pallor, and on inspection you can see the picture that a very big mass around his right axillary region, which was ovoid and with irregular margins. On palpations, it was around 5 into 3 centimeter, rubbery in consistency and fixed. Initially, his vitals showed a systemic compromise, so he required a noradrenaline initially, uh, possibly due to severe anemia and cytokine rewind vasodilation. So he was shifted to ICU initially after the lab reports. The systemic examination revealed massive splenomegaly and even hepatomegaly. So splenic involvement is very common in Hodgkin lymphoma and often correlates with bone marrow infiltration and advanced staging. Liver enlargement combined with earlier jaundice suggested a mixed picture, like there can be a possible cholestasis or marrow suppression, and or even cytokine effect on liver synthetic function. So his initial management in ICU was securing his IV access, and blood culture was sent, and random blood sugar was taken, his arterial blood gas was taken, and CRP. Since he had fever, we had to check for leptospirosis, dengue testing, and chest X-ray. So since he had very severe anemia, it can cause reduced oxygen delivery, contributing to fatigue and hemodynamic instability. So early transfusion and infection was to rule out, because pancytopenia may also reflect marrow involvement. So his investigation and his results were showing a pancytopenia picture, which means his hemoglobin is around 5.54, which is very severe anemic, and is WBC 2007-10, which is again leukopenia, and platelet count is less than 90,000, so which is thrombocytopenia. So altogether is called pancytopenia. And his peripheral smear showed microcytic hypochromic anemia with teardrop cells. Teardrop cells can reflect myelofascitic processes and consistent with the lymphomatous marrow involvement. So you can see his differential count is it is very variable. And coming to the liver function test and renal function test, his liver profile showed reduced albumin, mild hyperbilirubinemia, and elevated alkaline phosphatase, which suggested an cholestatic involvement or cytokine mediated hepatic dysfunction. But his renal shows were within the normal range, which shows that he's a true candidate for contrast imaging and chemotherapy planning for later on. His USG demonstrated hepatomegaly with fatty changes and massive splenomegaly. His ejection fraction was around 40%, requiring cardiac optimization. So cardiologist opinion was obtained, and he was told that to transfuse blood and make his hemoglobin around more than 10 and repeat an echo. Then in further treatment plan in ICU was vasopressor was tapered and blood glucose were corrected. Then 2 units for PRBC was transfused. Then IV antibiotics and necessary supports were given. So his hemodynamically was stable and hence shifted to ward. From ICU he was shifted to ward after he became stable. Then his PET-CT impression is multiple hypermetabolic right cervical, right supraclavicular, bilateral axillary, internal mammary, mediastinal and abdominal, and retroperitoneal iliac nodes were consistent with the lymphomatous involvement. So you can see in this picture, it was there was involvement of his axillary lymphomatous, and spleen was involved. Basically, there you can see some dots. There's actually many nodes were involved, and you can see in this picture there was also involvement of spine. So basically, the disease has disseminated other parts of the organ. So case was discussed with hematologist. He advised for lymph node biopsy and IHC report. So for lymph node biopsy, we again discussed with the surgery department for lymph node biopsy. So they advised to correct the hemoglobin around and more than 10 deciliter to carry out the biopsy. And after correction of 2 pins of blood transfusion, biopsy was taken. So you can see the picture of the lymph nodes of axillary node. So which is very inflamed and it got swollen up. So lymph node excision biopsy showed C15, C30 positive and C20 and C45 negative. So immunophenotype is characteristic of classical Hodgkin lymphoma, and C30 and C15 positivity confirm Reed-Sternberg lineage, while C45 negativity differentiates from non-Hodgkin B-cell lymphomas. So then patient was then referred to main center. He was referred to other center for chemotherapy since our hospital didn't have the chemotherapy option. Then he was referred to main center. Then since it was beyond his financial ability, they got discharged. But he was already in the stage 4. His survival rate was very low. Unfortunately, he was declared before getting into the treatment. So before knowing the diagnosis and treatment part, we should know the staging. So there is a staging called Ann Arbor staging. So stage 1 is single node region involvement. You can see in the picture, single node region involvement, and stage 2 is one side of diaphragm. So it should be involvement of either side of diaphragm, and you can third stage, both sides of diaphragm should be involved, both the sides of diaphragm, and stage 4 disseminated all over the body. with constitutional symptoms like no systemic symptoms, fever, night sweats, weight loss, extra lymphatic site, and splenic disease. So, coming to the treatment part, so there, so standard regimens for classical Hodgkin lymphoma can be divided into early stage and advanced stage. Early stage is again divided into favorable and unfavorable condition. So ABVD, which means adriamycin, which is also called doxorubicin, then B for bleomycin, V for vinblastine, D for dacarbazine. So ABVD is the standard regimen given for Hodgkin lymphoma. So in favorable condition, it is given for 2 cycles, and after 2 cycles, PET-CT is repeated, which guides us to de-escalate or escalate to remove the bleomycin if needed. Because bleomycin is very important because it can cause pulmonary toxicity. So basically, in many centers, they omit bleomycin and give only AVD. And in unfavorable conditions, they give ABVD for 4 cycles plus or minus ISRT, or brentuximab plus AVD in selected high risk cases. So in unfavorable and advanced stages, they continue as ABVD for 6 cycles, which is globally recognized as most common frontline regimens in advanced stages. And BVAVD, as I said, brentuximab vedotin with AVD. It shows it is proven that it is superior to ABVD in many trials, and they avoid bleomycin due to pulmonary toxicity. In some cases, they follow the PET adapted BioCop. So BioCop is a bleomycin, etoposide, adriamycin, cyclophosphamide, vincristine, procarbazine, prednisone. So this is very effective, but more toxicity to marrow, and it can also cause secondary malignancies. So in case of relapse or refractory, can they can call for salvage chemo. Salvage chemo it can be given in the therapies like ICE, GDP, DHAP, ESHAP, and followed by autologous stem cell transplant. So post transplant, the patient still goes on with therapies like checkpoint inhibitors called nivolumab and pembrolizumab, or if not, you can use brentuximab vedotin. So that comes to our end part. So basically, early favorable ABVD for 2 cycles, PET is done, and ABVD plus or minus ISRT. In unfavorable condition, ABVD for 4 cycles plus or minus ISRT. In advanced, ABVD for 6 cycles, or BV AVD for 6 cycles. In high risk cases, they go for escalated BIACOP with PET adapted. In case of relapsed or refractory Hodgkin lymphoma, they go for salvage chemo. And post transplant, they give checkpoint inhibitors. So that comes to our end. So if you want, I can also do more case discussion series, and yeah, thank you.